All right. We good to go? All right, welcome to Grand Rounds. Thank you, everybody. The last Grand Rounds of 2024 is here. So we are taking a break with Grand Rounds. We'll be off for the next 2 weeks. The next Grand Rounds is January 8th. January 8th is what I've been told, and you'll see it pop up here. We're halfway done through our Grand Round series. Next half is almost as good as the first half. We've got 3 international speakers coming, one from Peru, one from Zimbabwe, one from Germany, all starting there in February, and some incredible speakers throughout the US and internally here. So keep a lookout for that. And we welcome everybody to come back in 2025. My pleasure today to introduce somebody that really doesn't need much of an introduction. So I'm going to keep it short for Dr. Schwartz and the Department of Medicine Grand Rounds. Dr. Schwartz completed his medical degree at Duke University while simultaneously obtaining a PhD in cardiovascular physiology. He then ventured west and came here to the University of Colorado for his residency and chief residency. And then he continued to go west to San Francisco. And in San Francisco, he did a fellowship in cardiology and ultimately stayed there until 1999, where he rose to associate professor. We were fortunate to attract him back here in 1999, and he came to serve as the chief of cardiology at the Rocky Mountain Regional VA, a position he still holds a mere 25 years later. He also serves as the Director of Cardiology Outpatient Services and Director of Non-Invasive Cardiology Laboratories, as well as an attending clinical physician there. He's a full professor here at CU. Dr. Schwartz's research portfolio is vast. I'm not going to attempt to summarize it. He has 36 years of continuous NIH and/or VA funding as a principal investigator. He holds 3 patents. He's authored over 200 articles. It goes on, and we are certainly appreciative of his efforts. Please join me in welcoming Dr. Schwartz to the stage.
Okay, thank you very much for that kind introduction. And, you know, you can't believe half the things you hear on the street, so that would be my editorial comment on the introduction, but thank you very much nonetheless. So this is my topic, lipoprotein A from risk factor to target of treatment. These are my disclosures, and I just want to call your attention to the second, the lowest bullet point. I am going to talk about the use of PCSK9 inhibitors in patients with elevated lipoprotein A. That is not an approved indication for their use. So instead of starting off with a traditional case, I thought I would share 2 cases from the lay press that are relevant to lipoprotein A, because patients are learning about LPA and asking about it, will likely ask you about it. And this is the kind of material that they'll see. So on the left, you see a picture of Bob Harper, who was a celebrity fitness trainer who had a premature myocardial infarction, eventually attributed to elevated lipoprotein A as his principal risk factor. This was in the New York Times a number of years ago. And this is on the current American Heart Association website. So they have a page on LPA, and they have another little case presented. Sandra Tremulis adopted a healthy lifestyle, prioritized annual prevention, maintained normal cholesterol numbers, but nonetheless at age 39 had an MI caused by a 95% coronary stenosis. And the problem was attributed to a high LPA. And then at the bottom, the Heart Association tells patients who ask, what should I do about a high LPA? Basically, they list the Heart Association's simple 8, which is what they tell everybody to do. Take your meds, eat healthy, exercise, sleep, don't drink, don't smoke, control your weight, etc. So LPA is in the news, but it's not new. It was discovered in 1963 by Kari Berg, who was a geneticist at the University of Oslo. It was kind of a serendipitous discovery, but nonetheless an important one. So what I'd like to talk about this afternoon is what we've learned about LPA in over 60 years since it was discovered. And we'll talk first about its structure, function, and measurement, its association with cardiovascular disease, what guidelines tell us to do about it, how can we lower LPA with tools that we have today? And what does the future hold for tomorrow with targeted therapies? And finally, are there any concerns about lowering LPA? So let's dive into the first part here. So this is a schematic of the LPA particle, and it is a type of low-density lipoprotein. It contains ApoB100, which is common to all atherogenic lipoproteins. And in the case of LPA, it's bound to another apolipoprotein called ApoA, which has this long tail that you see circling the particle. And because it is an ApoB-containing particle, it is atherogenic. Furthermore, the ApoA, the little ApoA, the tail that you see here, has a structural homology to plasminogen, which is shown on the right. The kinase portion, the protease portion of ApoA is a dead protease, but nonetheless, there's thinking that there may be competition between ApoA and plasminogen that could affect a thrombogenic tendency. And there are also effects of LPA on the tissue factor pathway, so it may have thrombogenic properties. There are many isoforms of LPA that depend on how many of these Kringle repeats that you see in yellow are contained in the particle. And we each inherit two forms of LPA, one from each parent. And there may be anywhere from 4 to 40 repeats of this Kringle 4 type 2 that's shown in yellow that determine the isoforms that we have. People with smaller isoforms, fewer repeats, tend to have a higher concentration of LPA because the liver can presumably synthesize it more rapidly. And on the particle in green, you'll see what's being schematized as oxidized phospholipids. So these are oxidized moieties on the surface of the lipoprotein particle that are thought to be intensely pro-inflammatory and may have something to do with the risk conveyed by LPA. So why do we have LPA? It's only expressed in a few species. So we have it, non-human primates have it, but your pets don't have it, the animals on the farm don't have it, but this guy has it. It's a hedgehog. So for species as different as human and non-human primates and hedgehog to have the same lipoprotein and others not, it means there were two separate evolutionary divergences, and there was some adaptive value in both cases for retention of this particle. But we still really don't know why we have it. It's postulated that LPA may have a role in wound healing, in angiogenesis, and in thrombosis. An adaptive role in those cases, we'll talk more about that. And it is an acute phase reactant as well. So let's talk a little bit about how we measure LPA. So the gold standard is to measure it by mass spectrometry, but that's not scalable for a clinical lab. So all commercial assays use polyclonal antibodies directed at epitopes on those Kringles that I mentioned, the Kringle 4 type 2. And they may report either in mass units, so milligrams per deciliter, or in nanomoles per liter, in molar units. And this is a big source of confusion among providers and patients especially, because the numbers vary considerably depending on what units are used. There's no fixed conversion from one to the other. It depends on isoform size. But if you were to average a whole population, approximately 1 milligram per deciliter is equivalent to 2.4 nanomoles per liter. And what are the thresholds that we generally associate with elevated cardiovascular risk? So in mass, probably 30 to 50 or above milligrams per deciliter, or in molar concentration, 75 to 125 nanomoles per liter or greater. And it's important to recognize there's probably about 1% of the number of LPA particles in circulation as LDL particles. So as we talk about how toxic LPA can be to the cardiovascular system, on a per particle basis, that's really an astonishing kind of effect because it's outnumbered by LDL about 100 to 1 in circulation. So does it matter if your lab measures LPA in mass or molar units? Probably not. We did a comparison of 3 measurements of LPA, mass spec, mass concentration, molar concentration by immunoassay in 12,000 patients in the Odyssey outcomes trial. And you can see these bland Altman plots comparing the mass and the molar assays left and right to the gold standard mass spec. And they're all pretty tight. And the molar assay is probably a little better. It's important to recognize that the distribution of LPA in the population is highly skewed. So these are data from the UK Biobank, about 500,000 individuals. And you can see the right skew in the distribution. On the left are people who did not have prevalent atherosclerosis when they entered the cohort. And you can see in those people, the median level was about 19 nanomoles per liter. And on the right, the people who entered the UK Biobank cohort with atherosclerosis present had a median level of 29, so about 50% higher. So when you look at patients who have evident disease, you're going to find high levels more often. And you can see that also in that right-hand tail that's in red here. If you do a cut point at 150 nanomoles per liter, absent prevalent disease, that level is exceeded in 12%, present prevalent disease on the right in 20%. And another important fact about LPA is that the levels differ both by sex and by race. So let's spend some time looking at that. So this is again from the UK Biobank. These are levels in women versus men. Levels in women on average in this cohort were about 25% higher than they were in men, 22 versus 17. But it really depends on when you measure it in a woman's life course. So estrogen suppresses levels of LPA, and therefore at menopause, and you can see the separation of the levels in women versus men on the right at about age 50, at menopause levels go up in women, presumably because of estrogen declining. What about pregnancy? So you would think if estrogen suppresses the expression of LPA, that it might be low in pregnancy, but actually the opposite is true. So it goes up in pregnancy, sometimes as much as twofold. We don't know why. We don't know what's leading to the higher expression of LPA in pregnancy, but it may get back to the adaptive value of LPA in angiogenesis, promoting development of a healthy placenta, or perhaps in thrombosis and wound healing in terms of survival advantage during childbirth. Let's talk a little bit now about levels by race and ethnicity. So you can see here, again, this is the UK Biobank on the left, that a prominent difference is that levels in Black people are approximately double in this cohort. Some people may say more like 50% higher than they are in other racial groups. So the lowest levels on the right tend to be in East Asians, highest levels in people of African descent, and then in between are South Asians and white people. And you can see here from another independent data set, this is in the US, the multi-ethnic study of atherosclerosis. You can see the histogram and the box and whisker plots for 4 different racial groups and ethnic groups. And in Black people, levels are substantially higher. And we're going to talk about what that means, how to interpret that, how to make that actionable a little bit later in the talk, but it's a very important point. And so this difference in LPA concentration, you might say, well, is it related to the number of Kringles, to the isoforms? And the answer is no. So you can see on the left a histogram in Black, white, and Hispanic participants in MESA by Kringle number, and there's some differences, but they're not really striking. And on the right, you can see that in each demographic group, by 3 categories of Kringle numbers, the LPA concentration is always higher in Black people than in whites or Hispanics for the same number of Kringles, for the same isoform size. So we don't know why levels are higher in Black people, but this is an important thing to recognize. Finally, in terms of measurement, it's important to take account of the fact that LPA is hiding in your measurement of LDL cholesterol. It is a form of low density lipoprotein, and the LPA particle contains cholesterol just like LDL particles do. And either direct or calculated LDL incorporates the cholesterol that's in LPA. So on average, and there's a lot of inter-individual variability in this, again, on average, the LPA cholesterol content is about 30% of the LPA mass in milligrams per deciliter. So for an example of how that might be important, if you had a patient whose measured LDL was 130 and their LPA was 100 milligrams per deciliter, that 100 milligrams per deciliter of LPA might be contributing 30 milligrams per deciliter of cholesterol to your measurement of LDL. So actually a corrected LDL would be about 100 milligrams per deciliter. So why is that important? It's important because statins do not lower LPA, and therefore they don't lower the cholesterol component from LPA. So if you have a patient who you think is adherent with statins and their response is less than you expect, that would be a really good reason to check their LPA, because a high LPA may be a clue to statin, the cause of apparent statin unresponsiveness. Should you measure LPA more than once? You have somebody who was low, they come and say, well, maybe I'm high now. Or conversely, maybe I'm better and I don't have to worry about it. Well, the answer is probably not in most cases. LPA is almost entirely genetically determined. There are factors like estrogen levels changing, acute phase response in the setting of infection or inflammation that may alter it in some people, but by and large, low is low, high is high throughout the life course. And with only 1% of the American population having a measured LPA level, the low-hanging fruit is measure it once in everybody before we start worrying about measuring it the second time. Okay, association with cardiovascular disease events. So LPA participates in atherosclerosis. These are human coronary atherectomy specimens that are stained for LPA, and you can see that they're heavily infiltrated with LPA. It gets into the subendothelial space, gets into the arterial wall, and it may not be that apparent on the photomicrographs, but the areas with LPA staining are heavily infiltrated with inflammatory cells. So they are not just bystanders, they're presumably, this is a participant in the process. What about LPA and incident cardiovascular disease? So a high level increases the risk of coronary, cerebrovascular, peripheral artery, and aortic valve disease. Let's look at that a little bit more. So on the left to right, you see the relationship of LPA levels plotted on the horizontal axis to incident coronary disease left, stroke center, and PAD events on the right. And the common theme here is that when you get above, let's say 30 milligrams per deciliter or 75 nanomoles per liter, you start to see an inflection. Those are people who are at increased risk for atherosclerotic cardiovascular events. And these are just examples. There are many data sets that corroborate this. And not only is it a risk factor for incident cardiovascular disease, but it's also a risk factor for recurrent events and complications. So here you see on the left coronary and cerebrovascular events, and on the right, major adverse limb events. In a cohort with established atherosclerosis, these patients had PAD, 1,169 of them, and they were dichotomized at high and low LPA at only 30 milligrams per deciliter. And you can see the patients with higher LPA levels were at much higher risk for future events. So you might say, okay, that's fine, but these patients may not have been on statins. I'm a great doctor and everybody I see is on a statin, so I don't have to worry about LPA anymore. Is that right? Well, not so fast. So this is a meta-analysis that we performed from 7 trials in 29,000 patients, all statin treated, looking at their risk of coronary events according to their LPA on statin. And again, you can see this inflection above 30, the risk starts to go up, and certainly at higher levels, even more so. Well, you might say, okay, those patients might have been treated tepidly with statins. I have my patients on 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. I don't have to worry. Not so fast. So on the right, we have data from the Odyssey Outcomes trial, which was in patients with acute coronary syndrome. They were all on high-intensity statin. You can see the risk of major events. We call that MACE in the business, major adverse coronary events. according to quartile of LPA, and there's a monotonic relationship despite high intensity statin. So now let's get back to the question of how we interpret and take action on LPA levels in Black versus white patients. So here you can see on the left the atherosclerosis risk in communities, or aortic, data. And what they did was they looked at participants. These were people without prevalent atherosclerosis at entry. You can see in the first column that Black patients had a higher median level of LPA than white patients, 12.8 versus 4.3. But then on the right is the hazard ratio for incident coronary disease for 1 log difference in LPA levels. And you can see that hazard ratio is identical. So if you are white and you have a higher level than another white person, you're at higher risk. If you're Black and you have a higher level than another Black person, you have higher risk. So this is something we need to pay attention to in every patient, and take that into account in assessing their risk and determining their best treatment. On the right, you can see, again, from the UK Biobank, that there is this monotonic relationship of LPA levels to risk in both white and Black patients. The confidence boundaries are wider in the Black patients because there were fewer of them, but the message here is the same. Higher levels, higher risk, no matter who you are. Same applies to women and men. These are data that we obtained in the Odyssey Outcomes trial. Higher levels, higher risk. These are all patients who had prevalent coronary disease, and this is their risk of future events. LPA increases the risk for calcific aortic valve disease. And here you can see data from the Karolinska Institute in Sweden, where they took nearly, or about 23,000, they observed 23,000 patients who did not have aortic valve disease evident at baseline. And they were followed for 14 years for the development of clinically evident aortic valve disease. And then they looked according to the decile of lipoprotein A in their cohort. And what you can see here, this is plotting the freedom from incident calcific aortic valve disease. So the lower curves are the worst ones to have. And you can see that the green and the red at the bottom correspond, or actually it's blue and red at the bottom, correspond to the 2 top deciles of LPA in this cohort, which corresponded to about 50 milligrams per deciliter or higher. They were more likely to develop aortic valve disease. What about a patient who already has aortic valve disease? You know, we have guidelines that say if it's mild, you don't need to repeat an echo for 3 to 5 years. If it's severe, do it more often, at least once a year. Well, does that apply to everyone? Maybe not. So this is an interesting study. This looked at the progression of prevalent calcific aortic valve disease in a cohort of just 145 patients who had mild to moderate AS at baseline and were followed for up to 5 years. So on the left, you can see their CT calcium score. In the center, their Doppler velocity through the aortic valve, and on the right, clinical events. And the patients were dichotomized at an LPA level of 35 milligrams per deciliter, so not that high. What you can see is that in red, 35 or higher, the calcium score progressed more rapidly between 2 measurements. The Doppler velocity increased more between 2 measurements. And again, the freedom from aortic valve replacement was worse. Death or aortic valve replacement was worse if you had a high LPA. So message here, patient with aortic valve disease, you don't need to replace the valve right now, but you know their LPA is high. 2 things. 1, they should tell their family members to get checked. And number 2, this may be a patient whom you want to surveil with repeat testing a little bit more often. That's not in guidelines, but I think it's common sense from the data. So what do the guidelines tell us about LPA right now? So there are many guidelines, as you know. Every society likes to have guidelines, but I've picked 4 here to show you, and they're listed in chronological order, starting with the AHA-ACC multi-society guidelines that were published in 2018 and are still the current guidelines from the Heart Association. And they're conservative and selective. They say you shouldn't necessarily measure LPA in everyone, but you should in people who have a family history of premature atherosclerotic cardiovascular disease or calcific aortic valve disease, or a personal history of the same that's not explained by conventional risk factors. Other societies take a broader view of this, and I think my guess is, I'm not on the writing committee, but my guess is the AHA-ACC guidelines are going to fall into line with the next iteration. But the European Society of Cardiology, European Atherosclerosis Society, Canadian Cardiovascular Society, and this year, the National Lipid Association in this country all say, for the most part, every adult should have LPA measured at least once in the life course. And if you don't know, if you don't look, you won't know. And if you don't know, you can't act. So we'll talk a little bit more about what those actions might be. But my recommendation is just check it in everybody, unless it's going to be a financial burden to do so. Okay, so what do you do with the information? Other than making your patient scared, worried, anxious, because now they know they have a problem they didn't know about before. Well, there are going to be some people who are going to feel that way, but I think there are things we can do. And therefore, again, it justifies checking it. And the first, as I said before, is family cascade screening. This is all genetic. So if you find a high LPA in somebody who's 50, they should get on the phone and call their siblings, and they should have their kids checked and implement aggressive preventive measures as soon as possible. But we can do some things beyond that, and we'll talk a little bit about apheresis and then PCSK9 inhibitors. So what can we do today for patients in whom we find an elevated LPA? So I've put those strategies in two categories. I've color-coded them. So the blue ones are non-specific approaches to reduce their global cardiovascular risk. So, they may have excess risk due to LPA, but they also have risk due to other factors. Let's try to control that as much as we can in someone who has this other risk factor. And then in green, we'll talk about the specific treatments that we have now. So, of course, everyone should get recommendations for therapeutic lifestyle changes. Does that change LPA? Not at all. It's all genetic. You can't make it happen or make it unhappen. But we should still encourage everyone and emphasize it even more strongly when they have LPA. Maybe it'll be motivational. Statins. Do statins lower LPA? Not at all. In fact, some people think they might raise LPA maybe 5%. But when you calculate a patient's risk using the pooled cohort equation, using the AHA prevent equation, using the European score equation, none of those take LPA into account. And all of those have been shown to improve their predictive ability had they taken LPA into account. So there have been analyses of all three of those. So if you have someone who is at ultra low risk and is 20 years old and has a little bit of an LPA elevation, do you need to start them on a statin? Maybe not. But if you have someone who the pooled cohort equation says has a 6 or 7% risk without taking LPA into account and their LPA is high, I would start that patient if they were willing on a statin for primary prevention. And there are data, again, post hoc, subject to confounding, all the caveats of post hoc analyses to suggest that aspirin, although in general not useful in primary prevention of cardiovascular disease, may be useful in primary prevention when patients have high LPA. This includes data from the Women's Health Study, from MESA, and from several other cohorts. So it's something to think about as well. And the NLA guideline, the last of the four that I showed you, actually says consider for that as well. Okay, so we've done all those things, and now the patient says, yeah, but I want you to lower my levels. What are you going to do? So there's two options today. The first is apheresis. So There are no randomized controlled trials of apheresis. There are observational studies, and one of them is what I'm showing you here. So this is a study that was done in Germany where they're most enthusiastic about lipoprotein apheresis. In about 170 patients, all of them had previous coronary disease events. And the red line here shows the boundary between the time periods before they started apheresis on the left and after apheresis on the right. So what you can see, and what's plotted here in the bar graph, is the number of MACE cardiovascular events that these patients had at each time point. So, the view from the last row is, yeah, after they started apheresis, they had fewer events. It's a good thing. And maybe, but obviously there's a lot of biases here, a lot of confounding. It's not controlled. And you can see it's not all about LPA. So the lipoprotein apheresis lowers both LPA and LDL cholesterol. And so you can see at the bottom left, what their starting LPA and LDL-C levels are. And then on apheresis on the right, you can see in the second from the right column how low they were right after the apheresis treatment. So they went down from 91 to 28 for LPA before and after apheresis, and 102 to 35 for LDL. So the clinical benefit, if it's real, it's hard to know how much of it is LDL reduction, LPA reduction. Nonetheless, this is the only FDA-approved treatment today for elevated LPA, and it's only reimbursable in patients who have hypercholesterolemia with a level of LDL-C above 100, established cardiovascular disease and on statin treatment, and an LPA above 60 milligrams per deciliter, which is about 150 nanomoles per liter. So not that many patients. University of Colorado is the only, as far as I know, the only lipoprotein apheresis center in the state. And the people to reach out to, if you do have a patient whom you think this might be indicated for, Dave Saxon, Jim Falco, and Steve Simon. Those are the three. Okay, what about PCSK9 inhibitors? So PCSK9 inhibitors modestly reduce LPA. And you can see that here in green. These are, again, data from the Odyssey Outcomes trial. And what I've done here is I've plotted the change on the PCSK9 inhibitor alirocumab, the monoclonal antibody, based on the baseline quartile of LPA. So the quartile 1, the levels were less than 6.7 milligrams per deciliter. The highest quartile, they were at or above 60 milligrams per deciliter. So as you might expect with the green plot, if you had very little or none to begin with, the change on treatment is going to be small. But if you had a high level, like in the fourth quartile, there was a meaningful reduction in LPA with PCSK9 inhibitors, probably about 20%. And the LDL-C reduction is independent. That's shown in red. That's the same irrespective with this drug class, irrespective of the LDL. So a small reduction, modest reduction. Is it anything we should even think further about? So these were the overall results in the Odyssey Outcomes trial. Again, this was about 19,000 patients. They all had acute coronary syndrome. They all were on high-intensity statin, placebo group, and then a group that got the PCSK9 inhibitor, which lowered LDL cholesterol, as you would expect. So what were the outcomes according to LPA levels? So here in blue on the left, this is the placebo group, dichotomized according to their baseline quartile of LPA. So you can see that the absolute risk of events, if you were in the lowest quartile, is about 2/3 of what it is in the highest quartile, or the highest quartile is about 50% higher. This is in the placebo group. So what happens when you give these people the PCSK9 inhibitor? So now that's filled in red on the left. And you can see that in quartile 1, there's very little benefit of giving the PCSK9 inhibitor. And conversely, in quartile 4, there's a pretty substantial benefit of giving the PCSK9 inhibitor. The LDL reductions are the same across all quartiles, so it's not related to LDL effect. And then on the right, you can see a forest plot, and that plots the treatment hazard ratio. So in quartile 1, hazard ratio 0.95, only a 5% risk reduction, despite a huge LDL-C reduction in people with low LPA. And conversely, in quartile 4, same LDL reduction, a more substantial LPA reduction and higher prevalent LPA levels. And now you have a hazard ratio of 0.75, 25% risk reduction. So if you look at that gradient across the quartiles, that's significant. So that's what we call an effect modifier, okay? So a risk enhancer raises risk in the placebo group. We saw that, the blue, right? High LPA, higher risk in the placebo group. That's a risk enhancing factor. But what we're seeing in the red and in the forest plot is what we call effect modification. So you give a treatment and the relative treatment benefit is related to the presence or absence of the effect modifier. So these results were replicated independently in another trial called Fourier with 27,000 patients. So we had 2 independent studies that say the same thing. And so it looks like people with high LPA get more benefit from a PCSK9 inhibitor. That's not related to the LDL-C reduction. It's probably not related to that 20% circulating LPA reduction. If I had to guess, it's that a high LPA identifies patients and identifies plaques that are amenable to being stabilized with this intervention. So again, this is not an approved indication, but if you're on the fence about whether someone should or should not get a PCSK9 inhibitor, I think if their LPA is high, it could tip the scale for you. Okay, what's coming up? So we talked about what we have now. What might we have tomorrow to make this a little easier task than what we have in front of us today? So complicated slide. I've tried to organize it in a way that'll be helpful. So these are 6 investigational drugs currently under study to lower LPA. And each MOA, each mechanism of action, I've given a different color here. So the first one on the top, pelacarsen, this is a liver-targeted, ApoA-directed antisense oligonucleotide. So inhibits the translation of the ApoA mRNA in the liver and therefore prevents the assembly and the secretion of the LPA particle. It's given by a monthly subcutaneous injection. It can lower LPA up to 80%, and it's going to be the first trial to report results to test this LPA hypothesis that's been around for decades and has never been tested. So the trial is called Horizon, and we expect to know the top-line results from this trial maybe in a year, maybe at the end of 2025. I'm not directly involved, but this will be very important news. It may not be the drug that we choose to use going forward. It'll be the first test of hypothesis. So the next group in yellow are 3 small interfering RNAs. These are also liver targeted, and so they have a what's called a GalNAc moiety appended to an oligomer, and that's how they get uptake into the liver selectively. They're given every couple of months by a subcutaneous injection. They last much longer than the ASO, and they're more effective. They appear to be able to lower LPA levels by 95% or more. There are 3 outcome studies already in progress, or 2 already in progress. Zerlasiran is completed phase 2, and hopefully through CPC in collaboration with Mark Banacco, we'll be starting an phase 3 outcomes trial with that agent this year. The next one is a very interesting drug in red. This is called muvalaplin. This is an oral agent. It does not work by suppressing translation of mRNA. What it does is it prevents the covalent binding of ApoA to ApoB, and therefore prevents the assembly of the lipoprotein A particle in the liver. And phase 2 data with muvalaplin were just reported at the AHA this year. It can reduce LPA up to about 65% once daily. And lastly, in green is CRISPR-Cas9 approach, gene silencing, permanent gene silencing of the ApoA gene. This has been evaluated in non-human primates with more than 90% reduction in their LPA levels. There is a phase 1 clinical trial with this agent in progress. I don't know where this will land in the portfolio of choices here. My thinking is that if people are afraid to eat GMO plants, they're probably not going to want to be genetically modified permanently when there's a drug they can take that's reversible. So we'll see. Here are some examples of what these drugs do. So this is pelacarsen in the phase 2 data. The asterisk shows the dose that they're using in the phase 3. So you can see it's about a 75% reduction in LPA. These are the data with olpasiran, the siRNA. You can see at the higher doses, given every 3 months, it pretty much obliterates LPA almost to nothing. And similarly with zerlasiran, this is just published in JAMA, similar kinds of findings. So these are very effective agents to lower LPA. Whether that translates to a very substantial clinical benefit remains to be seen. So we may be able to lower LPA quite a bit in coming years, should we have any concerns about doing that. And bottom line is the jury is out. It always is out. And every time we think we know something about biology, we're always humbled. So what might be some of the concerns about lowering LPA too much? So this is a meta-analysis of 8 cohorts looking at the association of incident type 2 diabetes with LPA levels. And what they've plotted in the forest plot is the relative risk in the lowest versus the highest quintile of LPA. So patients or subject, individuals who had lower LPA had a higher risk of developing diabetes over the observation periods of these 8 cohorts. And this was significant. And the magnitude of the effect was also quite pronounced, 1.38 overall, so 38% higher risk of developing diabetes if you had very low versus very high LPA. So big question, is that going to be recapitulated? 2 questions. One is, why is this the case? And the answer is, we don't know. And the second is, will it be recapitulated with therapeutics that take someone from the 5th quintile down to the 1st quintile? Again, we'll see. We did look at this in the Odyssey outcomes trial. So again, this was a relatively short-term clinical trial, about a 3-year observation period. And we had, this is a plot of the association of LPA levels at baseline in the trial with incident diabetes during the trial in patients who did not have diabetes at baseline and were in the placebo groups. There were 6,700 of those patients. They had 676 cases of incident diabetes, so a fairly large number. And overall, you can see the result here. If they had higher LPA, they were less likely to develop diabetes during the trial. And if they had low LPA, they were more likely. So if you imagine a patient on this plot who started at 100 milligrams per deciliter and then was taken with a therapeutic agent to next to almost 0, their risk of diabetes would increase substantially if this was recapitulated. We don't know. The other possible concern with lowering LPA is related to bleeding. So I mentioned that LPA may have a role in hemostasis, in wound healing. And is that clinically relevant? You know, maybe it was when we were hunter-gatherers, but is it relevant today? You know, we don't know. So this first piece of evidence is from the Copenhagen Heart and General Population Studies, 100,000 participants. And they were followed for, I think, 10 or 15 years for all kinds of events. But here they plotted major cerebral and pulmonary bleeding. So they omitted GI bleeding because I think there were a lot of confounders there. So this is cerebral and pulmonary bleeding. And again, you can see that in the patients with LPA in the 1st to 50th percentile, those are the referent patients, they had a higher risk of bleeding than patients who had higher levels of LPA. So the lowest hazard ratio for bleeding was in the patients with the highest levels of LPA. And this is a Japanese cohort at the bottom. I'm sorry there isn't a graphic to explain this a little bit more rapidly, but this is looking at hemorrhagic versus ischemic stroke in the same Japanese cohort, according again to category of LPA. So if you look at the top of the table, in the bottom table, the top part of the bottom table, again, the referent group are people who had LPA less at the low level, less than 10 milligrams per deciliter here. Then they had a middle group, 10 to 21, and a upper group greater than 22 milligrams per deciliter. And the age-adjusted hazard ratio diminished with higher LPA levels for cerebral hemorrhage. And that was not seen for non-hemorrhagic cerebral infarction at the bottom. So it's not like they were just people who had all kinds of stroke. They had hemorrhagic stroke. So is this going to be recapitulated in patients with cardiovascular disease, many of whom are going to be on dual antiplatelet therapy or anticoagulants in addition? We'll have to wait and see. So, summary, LPA from risk factor to target of treatment. It's a lipoprotein that has atherogenic, inflammatory, and possibly thrombogenic properties. It's associated with the risk of incident and recurrent atherosclerotic cardiovascular disease and aortic valve disease. Measuring LPA once in every individual is supported by several guidelines and by me. And at present, apheresis is the only FDA-approved treatment for elevated LPA. LPA may modify the effect of PCSK9 inhibitors to reduce cardiovascular risk. And finally, trials with targeted LPA therapeutics are just ahead of us. They will test this LPA hypothesis that reducing the level of this lipoprotein reduces cardiovascular risk, and they'll also evaluate the safety of that approach. So I want to thank you for your attention. I want to wish everybody happy holidays, and I'd be happy to take your questions.
Thank you, Dr. Schwartz. That was terrific. We've got robust questions. We'll go right into it. MFA's got it.
Thanks, Greg. Maggie Wehrman. You mentioned the higher levels of LP(a) in women. And my question is, if I'm going to measure an LPA in a woman, premenopausal versus postmenopausal off estrogen, what is the delta? Or should I just,
Yeah, that's a great question. So if I can paraphrase it, given the changes that occur perimenopausally, when should you consider a repeat measurement? In which patient should you repeat a measurement? So I think if you measure it and the level is 10 nanomoles per liter, you're done. If you measure it and the levels are, 70 nanomoles per liter in a premenopausal woman, I might measure it again because that person might be 110 or 120 after menopause. So again, nothing is hard and fast, black and white. There are certainly cases where it should be measured. It would be reasonable to measure it more than once when those values are subject to change. And, if someone has a rheumatoid arthritis flare, same thing, and their level is high. Well, let's say these drugs are approved in 3 years and you measured it while they had a flare of rheumatoid arthritis, it's an acute phase reaction and it's high. Are you going to commit somebody to a treatment that costs thousands of dollars for decades? No, I would measure it again when their disease is quiescent and see what it is. So there are going to be a lot of gray areas in there, but it's a great question. But like I said, the low-hanging fruit is across the country, despite these guideline recommendations, only 1% of American adults have had an LPA measurement. But I will say at the Heart Association in November, was anyone else there? AHA in Chicago. The biggest crowd was at the free lipoprotein A testing booth. And I got mine tested there, and for the first time. And so I think it's gaining traction. People are going to be aware of this, and they're going to ask about it, and they're going to want to be tested.
I was going to ask about the targeted therapies. Are any of these trials testing people with aortic stenosis, or
Can you talk into Mike a little bit, Liz?
We're looking at targeted therapies for LPA for atherosclerotic disease. Should we also be looking at that for aortic stenosis? And is it happening? Are we already doing that?
For early detection of aortic, I mean, the thing with aortic stenosis is if you do a good physical exam, you should know. I don't think anybody with an LPA needs to have an echo, but they do need a careful listen for a systolic murmur.
So my question relates to the diabetes link. And so there is an association between statin use and increased incidence type 2 diabetes. And is that also seen in PCSK9 inhibitors? And do you have a hypothesis of what this linkage is between lipid variation and
that is a fantastic question. What Dr. Ernest is asking is, statins lower LDL cholesterol, and high intensity statins at least increase the risk of incident diabetes. PCSK9 inhibitors lower LDL cholesterol by at least as much. Genetic studies show that patients who have loss of function in PCSK9 may have a slightly increased risk of developing diabetes. So in the clinical trials, both Odyssey Outcomes and Fourier, which together had 100,000 patient years of observation, there was no signal at all. So you'd say, why is that? I showed data that if you lower LPA, which the PCSK9 inhibitors did, you'd expect an increase in diabetes. And if you lower LDL cholesterol, the genetic data would suggest also you would expect an increase in diabetes, but the effect was null. So we looked, and these data are in press. I don't have a slide of it yet, but we looked in Odyssey Outcomes at the independent association of LDL reduction and LPA reduction on this neutral net effect on diabetes overall. And what it turned out to show is the more we lowered LPA with the drug, the greater the risk of developing diabetes. The more a patient who had greater LDL reduction, the less the risk of developing diabetes. Now, people have said there are some pleiotropic, if you will, anti-inflammatory effects of PCSK9. It's been shown that in patients with COVID, for instance, it suppressed the production of cytokines. And so maybe there's some islet cell protection that is afforded that's not directly related to the LDL effects. But overall, PCSK9 inhibitors, at least in the 3 to 7 year observation period of all the trials, do not increase the risk of diabetes. But buried in that data, I think, is a relationship, an inverse relationship of on-treatment LPA levels. So lower with lower LPA, more reduction, greater risk, and a neutralizing directionally opposite relationship to the LDL lowering. And what the mechanisms are uncertain, but that's what we found. That paper hopefully will be coming out in a couple of weeks. So it's a great question.
Dr. Schwartz, I have a question about the epidemiology of people with elevated LPAs. In people that have normal LDLs or in people that have no other cardiovascular risk factors, what proportion of them will also have an elevated LPA?
If you, if you say an indisputably elevated level would be about 100 nanomoles per liter, about 20% of seemingly normal people will have levels above that threshold. So it's a minority of people, but not a small minority, where we may need to pay attention. Great. Thank you.